I believe we are live at this point, and I'm going to get the slides up here. All right, Rachel, can you verify that you can see those slides?
I can see the slides.
Okay, perfect. Excellent. All right. We're still having some folks joining us, and then we will get started in a moment. Okay. All right. I'm going to take a look and see who we have, but I wonder, Rachel, do you want to get us organized for the moment around the chairs for the meeting?
Sure, absolutely. So this is Rachel Freeman. I am one of the facilitators of the Acute Care Advisory Council. We just have a few updates before we get started. Our two chairs are in a situation where they can't quite make it at this time. So we're going to ask Jessica Simisak if she'd be willing to chair. Jessica, I know this will be a new experience for you. So just know that we'll kind of walk you through it through the slides, and that'll set you up for the chairing process. We are live streaming, and so that information is something we always start out with, and we are going to begin here in a little bit. I know, Jen, you're getting things started with the roll call, and what we've been doing is kind of making sure we know who's in the room and documenting that first before we get started. Jessica.
Okay, do you want me to start with a roll call, or you want to wait for
Yeah,
that?
we'll let Jen do the roll call, and then we'll ask you to jump in for the beginning call to order.
Okay, that sounds good. All right. So, if you could just, and I apologize for the lack of eye contact, but if you could give us a verbal yes that you're in attendance. I can see you, but let's hear a yes. So, Tom Delaney.
Yeah.
Okay, Carol Backstrom. Tasha Mertz.
Natasha's here.
Brad Johnson.
Here.
Thank you. Susan Cousins. All right, Cindy St. George. That's great. Simon Warren.
Simon is here.
All right, Kathy Chambers. Jody Donati.
Hi there.
And Mary Cosling.
Here.
All right, Janelle Hubbard.
Here.
And Randy Baumgart. You're here? Perfect. All right. And let's see. Sheila Grissom. And Josh Berg. Nicole Mujic.
Here.
And Laura Arnold. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 10 people in attendance, and that meets the quorum requirements.
Fantastic. That was close, though. Um, okay, so Jessica, we will start out. We've just confirmed our quorum, so we'll have you call to order, and we'll have that documented as our first step.
All right, I'll go ahead and call to order. And I think our first step was going to be approving the meeting minutes from last council meeting.
It will be, I think, the one thing that we'll just start with as well is just a brief description to everybody who is on live stream or joining live, that there will be an open session, and that will be shared in a minute as far as the time. It'll be at 11 to 11:15 a.m. this morning. That there is the public viewing in person and the live streaming options. If you are live streamed, there is about a 20-second delay between the conversation in the meeting and what you're seeing live streamed. And there is an opportunity to provide comments in that using the email provided on this slide as well. And then an important note for those who are providing comments, that all the public comments are being sent directly to each council member. They'll be analyzed for themes and will be considered when the council develops their recommendations.
Do you want us to review the agenda first for today?
Yeah, I think that's great. I see on the agenda, we have confirmation of quorum, approval of agenda. So we want to make sure people are okay with the plan. And then there is something that we want Stacy or somebody from DHS to talk about oath of office. I'm not sure if that went out yet. So let's go ahead and start with approval of the agenda.
All right, so I think the agenda is being displayed and was also sent out. So once we get through those initial pieces this morning, we will move on to approving of the meeting minutes at 9:10, which is right now. Then move into positive support training, technical assistance efforts. So probably doing some review of strengths and needs, looking at the data sources that were requested at the last council meeting, and review those motions and the literature review that's resulted in that, and any homework or actions to stem from it. And we'll take a break and return and engage in an activity on evaluation questions to inform the report, which we all know is coming around the corner soon here. And these are some of the things we're going to do during that time: defining elements of evaluation, making a list of the core questions with linked purpose statements and the data that will answer the questions. And then, like Jenna had pointed out, we'll move into the open session time for public comments, and on site at Elmer Andersen DHS site and online. And record the questions posted for immediate and for right now, and then prepare responses for the next meeting. And then we'll prepare for our next meeting at the end, report on next steps, any assessment action plan needed, and then we will close at noon.
And I think, Jessica, we, and somebody remind me, Jen, I think that Josh last time just asked for approval of the agenda rather than a motion.
Okay, do you want us to run through the roll call, or just everyone given
I think everybody say aye if you're in favor.
Okay.
Aye.
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 Okay, I think that's about 6. Aye for myself, 7. Yeah, I think we've got everyone.
Anybody opposed?
Yeah, anybody opposed? Any nays?
All right, abstaining. All right, thanks, Jessica. Yeah, so I know that you haven't gotten the oath of office information out yet. We just want to let you know that there's just some paperwork that goes along with being a council member that is important for signature purposes. And so you'll be seeing that come out in an email as part of just the documentation of you as a member. I think that's the correct way to say it. So yeah, you'll get that soon. All right, so that now we can move on to the meeting minutes, Jessica.
All right, is someone going to post those, or are they linked somewhere?
They were sent to you in an email. prior to the meeting. So I can certainly pull them up, but if somebody had a chance to review the minutes, then
Does anybody like the time to pull up and review the meeting minutes from last meeting?
I can certainly do that.
I think we did that last time, but I also know we're on a tight time schedule, so if we don't need to, that's fine.
If I can find them and pull them up there, if that's what you would like to do here. Hold on 1 second.
And Danny, I see you listed on here. Do you want to just kind of take us through the minutes for Jessica?
I do not have the minutes, Rachel.
Jen's gonna post them here in
Okay.
a second.
Yes.
Yeah. She's working on it.
Yeah, it's just gonna take me a minute to get in there and make sure I'm displaying the final minutes. Right. I don't know if Rachel, if you have them close by too, that would be,
Okay, yeah, I do. I'll share my screen,
okay, that would be great.
but you'll have to close
Yep.
for a minute. And let's see here. Just move you guys out of the way here so I can find it. There it is. Okay, so in the email that you received, can you all see that?
Not yet.
Not see it.
Oh, you can't?
No.
All right, let me try it again. Thought I'd gotten it. All right, how's that? Can you see my screen yet?
Mm-hmm.
Oh, that's the MHA. Okay, good. At least you can see my screen. Okay. All right, now you can see this, yes?
Yes.
All right,
Yes.
perfect. So we'll go down to, this was what you received in the email, which is the agenda. And then the next page is the meeting minutes. Here you go, Danny.
Okay. So, looks like we just started off with the members who were there. We have 13 people who are present: Laura Arnold, Randy Baumgard, Joshua Berg, Jody Donay, Sheila Grissom, Janelle Hubbard, Brad Johnson, Natasha Mertz, Nicole I'm sorry, I can't say your last name before, I'd probably butcher it, so sorry. Susan Pleasance, Jessica Simonisek, Cindy St. George, and Simon Warren. Council members who were absent was Tom Delaney. So we did have a quorum. Additional participants that were there: Stacy Danov, Danny Dunphy, Rachel Freeman, Margaret Moore, and Jeffrey Pucel, who were facilitators, Amy Peterson, Juanita St. George, Rachel Wadmarka, and Tiffany Whitebird. So we just start off with the introductions and the start of the meeting. Meeting was
Right.
called to order. We reviewed the old minutes from, I approved the agenda, looks like. What do we do there? Okay. And motions were made to approve the agenda last week. So our agenda and our minutes were approved last session.
Okay, so it does look, Danny, like we did make a motion for the agenda. So we'll do that together when
Okay,
we do the next step for the meeting minutes.
okay. Next order of business was to review the vote and approve the meeting minutes for January, and that was approved. There was a motion. And then we talked a little bit about the outline for the written report that was happening. And we showed the definitions to help clarify the roles of the written report, focus on information gathering. There was a clarification that was made to focus on the council is to address the barriers to transition related to emergency room admittance, as well as individuals who are admitted into the hospital. There was a group discussion about the better understanding of the populations of people who stayed beyond medical necessity, either in the emergency room or in the hospital. There were motions made to approve the outline. And our facilitators were going to review the literature and actually come back at today's meeting to show what we had found through the literature with the data. Let's see. There was a presentation summarized related to acute care transition. Department of Human Services put together to address barriers to transition for emergency room and hospital placements. And this was presented by DHS, representing Tribal and Transformational Division, and also the Acute Care Complex Transition Team. We talked a little bit about the strengths and needs of the activity related to acute care services and positive supports. And we did have a written document about that as to where those strengths landed on our 3-tiered perspectives. Then we had an open session. And then we prepared for the next meeting. Discussed the outline of the report and the types of qualitative and quantitative data that we wanted.
And I think, Danny, we also talked about the date. So you see there's one to
Yes.
be determined at meeting number 6. So that's something we need to decide on. We just could not, Jen couldn't find a time that worked for enough people to get a quorum. Our suggestion is that maybe we use that time to, in between meetings, work on the report so that it's in more developed form by the time we get to meeting 7. So that's one possibility that we could consider on that. And we'll talk about that in a little bit later. So that is those are the meeting minutes. And so now I think we're at that stage of this process of asking for a motion. If you all are in favor of approving the agenda and the meeting minutes, we could do both, or we could do them separate.
Why don't we
Rachel,
do them all together?
yeah,
Go ahead.
Carol Backstrom did put in the chat that she had to miss last meeting and it wasn't on the people who were absent here.
Oh, thank you. Okay.
So this is Brad. I'll make a motion to approve the agenda and the meeting minutes as amended.
Thank you, Brad. A second?
This is Natasha. I'll second.
And we'll go for discussion. Any comments? No? Okay, so we'll, Jen, do you want to start the voting process for this, or did we just do ayes for this level of complexity? Any memories of this? I think we just had everybody say aye, or if they were opposed, because it's pretty simple.
I think that if nobody else opposes to that, I think that's a good way to move forward.
Yeah, we can move forward quickly. Okay, so Jessica, you want to kind of just call for whether people are in favor?
Yep. Anyone in favor?
Aye.
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 Any opposed? Anyone abstain? All right. I think that carries.
Motion passes. So, and we'll include both agenda and meeting minutes. Is that correct?
That was the motion.
Okay, so do you want to read it back to us, Jen?
The motion to approve meeting the agenda and meeting minutes as amended.
Great. And can you put the agenda back up for us, Jen, when you get a minute?
Mm-hmm.
And Danny, thanks for going through that with us.
The one thing that we there's the agenda. One thing that we have in here too that we should review are just the purpose of the council before moving on with the other agenda items.
Oh, I'm sorry, Jen. I didn't have that in the original notes, so
That's okay.
you added that in.
All right, and so we just pulled this from the ask for this council, and we'll be circling back to this later in the agenda, but also think it's a good way to start each council meeting, just as a reminder for the purpose of the council to improve regional capacity for acute care transitions, create a measurement and evaluation system using implementation science, and identify statewide strategies addressing geographic, racial, and ethnic disparities and addressing acute care transitions. The other element of this too is the futures vision that was developed based on the conversations and input from council members on during the first meeting. And so just centering us to the centering the council to the purpose of the council that and the vision that you all have for this work. We talked about the oath of office and approval of the minute meetings. And so Rachel, I'll hand that over to you.
All right. So the last time we met, we were going to go through just a really brief description of the types of positive supports in Minnesota. And so I'm going to try to do this fairly quickly. You can see this. Yeah. Jessica, you're nodding.
Yeah, I'm sharing the screen if you want to take over, but I can.
Oh, you're sharing the screen, so I can't drive.
I can let you. I'll stop sharing.
Okay.
You can share.
Okay, wait. I thought I was sharing, so I had the sharing button on. So I really did think I was sharing. Now I see. You can see my screen. Yeah.
Correct.
Okay. Yep. Okay, great. All right, so we'll go through this fairly quickly. This was from the last meeting. In the state of Minnesota, there's funds to help support something called positive supports. Quick definition is that they're person-centered and culturally competent and responsive. They respect human dignity. They're really any evidence-based or promising practices that fit the different types of supports that different people may need. But they also include ongoing assessment. So any kind of evidence-based practice that follows these four major pieces, and they're oftentimes implemented together, that is considered a positive support in the state of Minnesota. So I won't go through these. They're just different types of positive support strategies. Person-centered thinking and planning are really more foundational. The evidence-based practices are below, so you can see some different examples. Okay, so one of the things in the state that we've talked about a little bit is implementation science, that idea of moving away from a train and hope or the one-shot workshop, those types of things that we know are kind of frustrating for staff and families and others who, you have an introduction to content around a positive practice, but you don't actually get it in place. It doesn't stick. And so there are these implementation science strategies. There's other types of efforts that help us to make sure that if we're going to implement something and we're going to spend the money on a particular practice, that we do so in a way that really makes a difference. And so instead of just sending people to training, we start thinking about a whole organization or a whole family. We talk about the unit or the systems involved. And so when we think about a provider organization or a hospital or a mental health agency, you think about the whole system and you think about what from a particular practice do all people need to know about a positive support. And then you think about, okay, so how do we know when people need those positive supports, and how can we use our data to kind of trigger early intervention and problem solving before challenges escalate and become more of an acute kind of situation or setting. But we also know we all have those events in our lives where there's a emergency or a really complex situation that we're dealing with. And so by looking at a tiered model, you're able to really think about resource allocation in an efficient way. And so we've been working with teams to think about within a provider organization, mental health hospital, you think about a team that addresses the triangle, but then you might have a smaller team that addresses the some few sort of area of the triangle, those folks that might need a little bit more support. And so you can see that once you get to a tier 2 and 3 team, you have individual planning that kind of forms around each person to kind of tailor their needs. So when we think about this in the state of Minnesota, there are a lot of different positive supports that have really gotten attention and people have advocated for. These are the common positive supports. There are definitely more, and I might be missing some. But in these implementation efforts, there's also areas that we could do better. And I remember in the last meeting, we talked about systems of care and wraparound planning. Those are areas that in DHS, we're really looking at how do we help support increased training and problem solving around other types of positive supports that may not be as embedded within the state system. Others practices include mindfulness, acceptance and commitment therapy, people planning together as more of a person-centered effort. So I'm just going through this as a way to show kind of the efforts being taken right now to build that capacity so that folks in the community have the ability to support people as they transition from acute care settings. And we have sort of the support net around people so that they can be successful and thrive and improve quality of life over time. Okay, so as we look at this, this started out in about 2015, where there were county teams and provider organizations that kind of came together in the circled areas. So they were kind of pilots, and the next step is the idea of expansion. So there are just a growing number of teams that are systematically moving beyond the one-shot workshop or the train and hope model to really look at systematically training and changing the way things look by building that expertise for different types of positive supports. And each of those organizations are different. Some are public health systems, some are providers that support people who have a diagnosis of a traumatic brain injury or mental illness. Sometimes there are individuals who are being supported or served through the IDD or disability services system. So it just gives you a sense of the different groups that are starting to form and move forward with this kind of an approach, which kind of led us to that regional concept that Natasha has mentioned as well. Can we start building that support? Another piece of that is actually making sure that we can evaluate how well we're doing with our support for people. And so we think about the efforts that are taken around positive supports. We think about fidelity, which is how well we're actually implementing, given what's been said in the research about what needs to be in place for things like positive behavior support or applied behavior analysis or other types of practices. And then we look at those outcomes that are quality of life. They might be around incidents that occur. It could be around injuries, sick days of staff, attrition, workers' comp. All of those things are part of evaluation for our organizations. We have a tool that's called the Tiered On-Site Evaluation Tool, the TOET, and that is meant to, based on whatever type of evidence-based positive support you're implementing, that you have a way to show that you're really implementing with fidelity or implementing in the way it's intended. And then you're looking at those outcomes so that you have both pieces. You say, we have some good progress and we can point to the positive supports that appear to be supporting those positive changes. As we kind of move through that tiered on-site evaluation tool, the idea is to not just like have a survey or another type of self-report, but to have, you know, an external kind of person look at a couple hours on-site visit, or it can be virtual, where we ask questions, we look at policies, we look at the training materials, we observe and see what kind of changes have happened within a setting. And then that is a measure that we then use as a scoring tool. So 0, 1, 2, 0 being there's no evidence of a positive support element in place. 1 is like, it's kind of getting started. And then 2 is like, this is fully in place, right? So as we're moving forward, we're doing this so that we can see things like changes in policies, prevention-focused interventions, things around cultural responsiveness and strategies to improve how we support people within our organizations. We look at the different training, and then we really look at the information that we have. We collect a lot of data. We don't always use it strategically. And so that's what these teams have been working on. This graph just briefly shows you a subset of organizations that have been using this tool. And you can see over years the progress that they make. And then they also report the data. So you've got 14 here listed. You can see a couple organizations were part of the earlier training, and they weren't collecting this particular data. But this just gives you a way to show fidelity. And so that's what we're showing you here. This isn't actually one organization's data. So this is an organization that is about medium size, supports people who have a diagnosis of mental illness and or intellectual and developmental disabilities or traumatic brain injury, those kind of things. You can see on this graph, and this is again that fidelity of 0, 1, 2, the total number of items are about 36. So, 100% would mean they got it all figured out, right? So you see the subscales at the bottom are the different elements. So you've got, do they have a team in place? Do they have person-centered implementation going on? Do they have positive behavior support? What about cultural awareness? So you see from 2016 to 2020, those particular subscales really increase over time. Monitoring and database decision-making is hard. Do you see that progress being made? And then you see support for staff. So that teaching sort of part of the puzzle, visibility, getting out there to everybody, what's going on and how things are working to our community at large, and then the overall total. So this is the fidelity check. And then this particular organization, this is one of their outcome measures, which is incident reports. So they really spent time organizing, and you see from 2018, 19, and 2020 on this particular graph, the number of incidents really decreased. Now in 2020, that was a pandemic. So, there's some question about whether that is due to any positive support or it's about the context. But they did a really nice job. And I think one of the things that's interesting to see is they started to organize by major and minor events. So they are looking at, of the major events, that helps them know how many things are escalating, how many incidents are getting more serious, whether minors are more like maybe a medication error problem or things like that. So it helps you kind of look at and problem solve as a team, your data, and compare it to your fidelity data to see, are you moving in the right direction? So this was the first steps of one organization in really looking at implementing positive supports. Now, again, just think about this from the perspective of your own work or where you're receiving services. So you're thinking about really different types of positive supports. In this case, they looked at person-centered practices and positive behavior support, but in another setting, you might look at systems of care and wraparound. So it's meant to allow you to organize based on what you're providing around services and supports and that kind of thing. So I'm just doing a drive-by on this. I'm going pretty quick, but I want you to know some of the things that the state has really invested in. One is to expand those teams and those regions across the state, so more organizations have a chance to really implement with a high amount of fidelity. Also, really increasing the number of types of positive supports. When you saw the example that we showed you, it really was 2 subscales, one around person-centered practices and one around PBS. But what we're moving towards now is that sort of ability to kind of, for each organization, pick the kind of positive supports that they're working on and tailor that. Okay, another implementation effort is really continuing some of the positive support training, so that there's a positive behavior support awareness training that goes on each year, and that's been very popular. But also moving towards a next step in some of our positive supports that are really meant to be competency-based. So if you go to a training and you just learn information and you walk away, that's really great. But if you go to a training and you actually try out some different tools and you can implement those tools while you're working in your regular job and get support from somebody and who's observing and kind of helping you to really integrate and figure it out, that's a level of competency-based training that's really needed to address the acute care crisis. We have a lot of challenges right now, and just providing awareness trainings does not quite cut it. So this expand competency-based training section is a meeting that's going on now where we're bringing a subgroup, in this case, positive behavior support folks together. So all of the champions are invited to attend this meeting and really talk about creating some recommendations that would go to the state around how to really move towards a much more intensive training system. And the state has done some of these things in the past, so it's really a great way to kind of connect up to the discussions we've had about incentives and how we can create incentives for folks to really connect up with what's going on with different positive supports and the home and community-based waiver services and other types of things that are available for people to be able to implement and receive reimbursement for the work that they're doing. The last piece is regional team building. So those circles you saw earlier, those are different areas with regional teams either starting or some that have been implementing for many years. And this regional capacity building is one of the pieces of the puzzle that we know is needed because there are so many brilliant people in our state. They're doing really important work. If we can figure out how to leverage and support them, they're going to be able to help other organizations and families more effectively. So one of the things the state is doing is looking at a statewide process where we have our local implementation, but then at these regional team levels, we're sharing information about how many trainers are in the region, what kind of things do we need to make sure that people have what they need. Is there enough communication going on within the region about how to access different trainings and information? And then that information gets shared to a state team, and the state can then think about how to disperse resources, how to support our regions more effectively. So that's kind of in a nutshell, sort of the efforts have been going on for the last few years to really start to change how we're doing things, moving away from just offering trainings and hoping that that works. This is a path, and if you're not familiar with it, it's called a person-centered plan. It's been actually applied at one regional team at the actual regional level. And so the visual is a planning process. What you start with is the dream for the region. And so a group of people that included provider organizations and county folks, and actually this comes from Danny's area of the state. They talk about what do we want to achieve? And what they talked about is making sure families know where the resources are, that when we have meetings from an interdisciplinary point of view, that we know what each other's roles are so we can better support our families as we meet to help problem solve in meetings. To make sure that people have access to the trainings that are available and that people could be going to if they know about them. So that's just an example of a path process that's coming out of the north area of Minnesota. And they are actually meeting today, I believe, Danny, to kind of continue their efforts at implementing positive supports. So that is a very quick overview that I was meant to do at the last meeting, and it really just sets the stage. So this was one of the last steps before we kind of dive deeper into the data that I wanted to just make sure you knew about. There's some trainings going on, and we just had a really big motivational interviewing virtual webinar that had 217 people. So people are interested, and it's been exciting to see and connect up with the different people. Just call your attention to the mnpsp.org website that allows you to kind of see different positive supports that might be of interest in your area. And then there's also a training material section for our teams. Okay, I am going to stop there. And that kind of completes the 9:25 to 10 o'clock. So it gives us a little bit more time, I think. to be able to talk about the data, which is a little bit more complex. And I think that'll be a good way to proceed. But before we do that, just kind of having a quick conversation about strengths and needs that you all see with regards to positive supports, because I know we're a very diverse group. Any thoughts? This was meant to go along with Amy Peterson's presentation from the last meeting. And I see Brad. I wanted to just mention to you, Brad, that some of the resources that are out there are connected to like JJA and trying to figure out how to make sure judges and other folks understand some of these practices, things like trauma-informed support, so that they can then maybe sort of see things differently as they're supporting the people that are coming through the justice system. So I wanted to mention that too. That's one of the things that's really important. Some states have whole systems. I know Jen was involved in the state of Maryland supporting juvenile justice associations or organizations that are kind of doing this kind of model.
And I'll jump in here. This is Natasha, everyone. I think one of the reasons that we wanted to kind of do an overview of positive supports and sort of connect it to the acute and complex care transitions work is that we know that often people that are stuck in hospitals are at that sort of tippy top of the public health triangle, or maybe in that secondary intervention, but often at the top, where we really need to have to support people in community or at the right level of care to get them out of that hospital or out of that acute care setting that they no longer need. We need a system that's able to provide those really coordinated positive support implementation strategies where you are, as Rachel talked about before, like, kind of picking from a few modalities that are evidence-based and share those values to be able to train providers, to be able to train, to be and implement and train going forward. So what I'm hoping is that this group kind of sees the connection between the work that we've done or the state's done and the U.S. done overall with positive supports, and then saying, how do we leverage some of those strengths, those regional supports, but then focus it specifically on acute and complex care transitions, that there are lessons and things we can draw from that capacity building and then apply it in a much more specific context. Because much of the work that we've just described has been also to build overall system capacity in the wide variety of positive supports. So I think one of the ways I think about solving for this problem, the issue why we're here today, is to be able to take some of that work and then apply it in a very specific context for acute and complex care transitions. So not that positive supports work overall is going to just automatically solve the problem, but that it provides us with an approach and an infrastructure at a regional level that allows us to do something very specific in the context of complex transitions.
Thanks, Natasha. I think that's a really important piece of the puzzle when we're going to go into the motion about collecting data here in a minute. And what we see are kind of two different angles for which we as a council need to address and collect information. One is discharge delays. And so that's where we were starting. And, a lot of the recommendations are around things like having emergency beds and different types of strategies like that. When you kind of look at the community services, that when we're actually providing really effective community services, then we don't need as much around beds because we're able to kind of provide those services within the community. So those are both important pieces of the puzzle, and trying to figure out as a council how to move forward in the way that Natasha, you have been talking about, which is we need measurement systems that kind of bring us together. How do we do that in a way that shows effective transition planning? And we have folks moving into the community, and the community is prepared to provide those supports. And we have emergency sort of services that allow us to provide support in a way that's needed for people, but we're getting people back into their community settings. So that's kind of the logic behind giving the council a little bit of information about what's going on with positive supports in the state and that idea of regional kind of capacity building. Any needs that we're thinking about as you were listening to the presentation, areas of focus? Okay. All right, well, Jen, should we go ahead and put the agenda up, or should we dive into the next section?
I have the agenda queued up right now, so I can share that and then we can move into the next.
You see where we're at.
Yeah, I want to, we are about 12 minutes early on the next topic.
And I was hoping we'd have a little extra time for this area because it's the area of interest from the group.
That's what I was gonna say too, that if that's where you want to transition into, if the group is okay with that, and Jessica as chair, I would defer to you on that. I don't think I see Jessica on here at this point.
I think she got bumped off.
Okay.
Okay. Well, let's just go ahead and jump into this, and she'll probably be back. And I think the slides are on your slide deck, right?
Sure, I can drive that.
Can you make this a little bigger? I don't know if you can make it. Can everybody see this? Okay.
I can make it bigger, and I'm gonna stop for a second so you don't have to see.
Okay, so as Jen's doing that, we had a motion last time to gather data. And so one of the things that we've been doing is a lit review that's larger, but our first step was to see what is going on in the state of Minnesota. But we also looked at some outstanding states as well. If you can just go back one slide. Yeah, so the idea was to start out with the data related to discharge from hospitals and the delays, to look at Minnesota-based information, then do that larger literature review that I believe was the next motion in the last meeting. So we'll go ahead and show you where we're at with progress. If you go to the next slide. And this is the actual motion. So the idea was to reach out first to Susan Pleasance to obtain data related to transitions from the emergency department, from hospitals, and then look at how that information is available. In the meeting, we talked about source data and how we needed to try to stay close to source data. We needed to, we also recognize that it's not always available, but if we could get to a point where we have public reported information in a way that gives us that confidence that we could proceed. So our discussion was kind of in that area. And so what I'll show you is where we're at with this on the next slide. We've been looking at the literature review, but as you kind of see from the conversation with positive supports, there's a lot of different angles that we might proceed with. We're starting with the discharge delays. We found 8 reports that are in different sort of formats that are from Minnesota that are around the discharge delay. So we'll go through some of those today. We also know that the Minnesota Department of Health is right now finishing up a study around discharge delays, and it's not quite, I don't believe, ready, right, Carol? Carol's here today, isn't she?
She is.
Yeah. So I'll show you the information that's on the website for the MDH data. And then what's really interesting is, I think, and it speaks to Minnesota, which is there's some other states that are doing very similar types of reports and seem to have been driven by our MHA, Minnesota Health Hospital Association's data. So they had done an original 2016 report. And then there's the one that Susan Pleasance has told us is available as a presentation, but is not quite out in a report sort of format. What I found interesting is the state of Maryland, where Jen is from, actually did a report a little bit later. I think it was in 2019. We'll see that in a minute. That is by Wilder, and looks like it was like a continuation or a focus on that state's discharge delay. And then there's another set of data that comes out in New York. And so when you look at all of these reports together, the patterns start to show some really clear similarities and triangulation. So that's something that I wanted to mention. I do have other like peer-reviewed documents and gray materials. We decided to focus just on Minnesota first. And so we'll be kind of doing a little bit today about the larger lit review, but kind of digging into this issue around Minnesota. Okay, we can go to the next slide. Okay, so 2016, the Minnesota Hospital Association has an online link that you can go to and get this document yourself. We'll make sure that you have a copy of this so you can go dig through the information. It was conducted by Wilder. It was a 45-day study with 22 hospitals in 2016, March through April. And the basic information was 6,052 out of 32,520 days were avoidable discharge delays. Oh, I'm seeing that Susan is having trouble getting on. Is that?
No, we're good. We're good. You can keep moving forward.
Okay.
Yep.
I was hearing the dings. I thought I would check. So that's a 2016. And then we did reach out to Susan, and Susan, are you on the call now? Yeah. What we know is that Susan has offered a PowerPoint presentation on the 2022 data. What I saw from the blog, and you can tell me, Susan, if this is right, but it's a 7-day study, December 11th through 17th, 2022. 2,000 patients eligible to transition were delayed, and that there were 14,622 extra hospital days. In the Star Tribune, there's a bunch of different newspaper articles on this. They mentioned 65,000 more days inpatient hospital beds than needed in the 5-month period ending in October. So this is what we have from our Minnesota-based reports. And I didn't know if Susan, you wanted to mention anything about, because I know you and Jen talked, right?
I don't think we spoke. We've connected via email in the last week or so. The MHA has quite a bit more data than that, but I asked them about, getting us the data and helping us understand it, because that was my understanding of our conversation last time, was that we wanted something that people could consume. So I think we just didn't get the source data yet, but they did 2 multi-month studies, so it wasn't just a 7-day study.
Oh, fantastic.
Yeah.
Okay, that's great. So is that written up somewhere, Susan, that we can get access to, or is it in process, or?
I mean, it's not published, it's just collected, and I did connect the person with the data with your team, but I just looking to see what the outcome of that was. Somebody else might know.
Yeah, Jen, do you want to speak to the steps you took?
Certainly, yeah, we were in email communication, and the communication was that the data were in process, but not I think in a place where they would be able to be shared at this point. I can certainly circle back to that and keep that going under the existing motion.
That sounds great. Well, let's do that then. We'll continue to communicate, and it sounded like there was some offers to, like you said, Susan, share the information so that it could be kind of presented in a way that really made a lot of sense. I think, the thing that I came out of this with is the fact that this 2016 report seems to have triggered some other states doing similar sorts of work with Wilder or on their own with other organizations. So let's go ahead and go to the next page. This is, and I just grabbed this as a screenshot. We can go to the actual reports. But I think what we're going to do at this point is just sum up what we're seeing across the different state systems. So you see, this is a visual that came out of the executive summary for 2016 for the MHA, and it shows a focus on beds. So state psychiatric hospital bed unavailable, chemical dependency treatment bed not available. You'll see the numbers on the side. Intensive residential treatment services bed not available. Sorry, there was an echo there. State psychiatric hospital bed unavailable. group homes, awaiting community access, and then waiting for services for placement. So that's kind of the types of Minnesota Hospital Association data that we probably will see variations. I would imagine, Susan, that you kind of built on some of the methodological processes. Okay, next page. So the other piece that is in process is the Minnesota Department of Health study. And that one is, it was a 45-day period from September 5th through October 20th. Each hospital is being asked to kind of collect data, and that happened and is in the process, I understand, of being summarized. And Jen, were you the one who checked in on this one too?
I did. It is in the process of being summarized. And so it's not available yet, or the data are being pulled together at this point. So we'll have an update on that as soon as it's available.
And I can speak to this one if that's all right.
Yes, please, Carol. Thank you.
Hi. Yes, the staff are putting the report together, and I'd love to be able to bring it to this group at some point, and have the people who actually did the study kind of do the walkthrough, because I think that would be a nice snapshot of what's happening.
Great. And that sounds like similar to what Susan is talking about as well with the MHA data, is like having a kind of presentation walkthrough. The other thing that I saw, Carol, is there are some documents online, some of which actually identify measurement definitions. And I was thinking that that is something that we will want to do, is really look at across these different studies, adopt or consider the different types of ways that we can use what's already been created to create that consistency and unification. So I was excited to see
Fantastic.
Sorry, what?
Fantastic. That's terrific to hear.
Yeah. I loved the documents that are available online because it actually goes through and presents some of that. We'll make sure that everybody can access the public links to all of these, because it's been really helpful to see what you're doing, Carol. It was exciting to know that it's coming right out the gate. So
great. Looking forward to it.
Super. All right. So if we go to the next page. Maryland also did a study, and it was Wilder that drove this one, and it looked like it was a similar, they use slightly different measurement systems, but they are looking at a similar sort of process. So now we have 2016, we have 2019, and you'll see New York at 2022, and then we'll have both our Minnesota groups kind of give us the data around the current information. But in Maryland, they had 29 hospitals, April 15th through May. So you see some groups are kind of heading in that springtime period. 4,748 behavioral health patients were treated in the 45-day study. 2,000 of the 4,748 patients, or 42%, experience a discharge or transfer delay. And here's where things start to get interesting. You know, you start to see some of these patterns across the states that are similar to what we're seeing in Minnesota. We'll just go to the next slide. Each of these will have the links to the actual reports. New York has two reports. One is like a kind of a sum up big picture, and then there's a pilot and a survey. They have done something that I really wanted those of you who are involved in studies to look at. So they did theirs April through June. They had 52 hospitals involved. So they had 1,115 patients impacted with 60,000 delay days and $169 million in estimated costs. So as we start to see these patterns come up, the average delay is about 2 months. Children and older adults are coming out with sort of more frequent and or longest. So you see the pilot results at the bottom in the blue. What we're seeing is older than 65, there's more frequent visits. Medical complexity are more frequent. The longest delays, and this just seems to be showing up across groups, is younger than age 18. individuals with intellectual and developmental disabilities and or mental illness, comorbid sort of diagnoses, those kind of things tend to be associated with the longer delays. So remember that meeting we had where we were talking about who is impacted. These reports are kind of summarizing by this type of information coming out of their survey data. And the cause is lack of care options on when we're looking at our older adults, but also guardianship and agency process. So those are things the New York white paper has kind of reported. And if you go to the next slide, I think this is the one. Nope, they did have a nice, then again, these are screen captures from the link, so you can go straight to the link for these. The really important point they're making is that systems of care message, that our hospitals have all of these different systems that they're having to communicate with, right? And that communication across systems is a really big challenge that obviously has an impact on delays and that sort of thing. So I thought that was a really interesting way of kind of showing the complexity of the situation, where you've got police, you got transportation issues, you've got the state, you've got social services, you've got agencies and hospitals, and it's a very complex situation. And if you go to the next slide, they, and I don't know if we can make this bigger, but again, across Maryland and New York, you're seeing children and adults, older adults with medically complex or behavioral health conditions, those children with intellectual and developmental disabilities or comorbid diagnoses. These are the folks that are experiencing longer delays and or more frequent ones. And I thought this was an interesting visual that the New York group put together. So you see transportation, legal process, and care options, and then they kind of map out the different areas that are coming up in their analysis. So under transportation, there are limited hours, limited accommodation for wheelchairs, things like that, insurance-related delays. Under legal process, guardianship is coming up quite frequently, and I know Natasha, you had a presentation that was talking about children and family services. So I think, as we think about the delays, that we're getting some really clear kind of indicators that this is a national issue, and that there's some signals on how we might engage in problem solving. The bottom part of that arrow is housing, care planning, and payment sort of issues. So I thought that was a really helpful way of kind of organizing what's coming out and explaining these discharge delays. And as we as a council move forward, we're thinking about what are the ways we can, share that literature review that was in the motion, but also show our Minnesota data and really kind of come up with some strong recommendations for how we might proceed forward. Okay. Let's see. I'm not going through all the details. I think, for those of you who are interested in what we'll try to do is summarize some of these things. But if we go to the next slide, the part that kind of leads us to actions and or emotions are that, like Carol mentioned, we have this potential to build on what's already been implemented. There are surveys that MHA has in their appendix. There's the Maryland study, and they have some slightly different ways of measuring. And then there's the MDH study that's coming out around the bend here. So I feel like that might be one of the things we can do. And Natasha, you had mentioned like next steps are to look at creating that unified measurement system that we can all kind of get behind and move forward with. This may be one of the places we want to dig in a little bit more. There's some other reports. The Minnesota Medical Association has some really excellent definitions that they've mapped out, and some really great ways of talking about the discharge delay. So that's another report that I think is really important for us to kind of really digest. They've reported a lot of MDH data, Carol, in that report. I don't know if anybody has seen that one. I'm going to take us to the next slide and see where we're at here. So far, we've just talked about the larger Minnesota related details. We also have a literature review undergoing sort of a process because there are different topic areas that we need to kind of dig into based on those questions that Jen started us off with. We have those 3 areas around regional capacity, measurement systems, and really understanding disparities and how we can create equitable kind of processes around our acute care systems. So that suggests different lit search areas. We have started obviously with the discharge delay, but we also are looking at things like the foster care and experiences of children and families. When we look at health equities or inequities, we have a number of different things that we know are happening across medical systems and in particular relating to the acute care kind of issues that are going on. There's also the emotional behavior disorder literature, which has a lot of information that's really helpful on transition planning. And there's a lot of literature and systems of care that speak to this natural challenge of building capacity in our communities versus investing in institutional settings. They're both, there's a balance for these things that we need to figure out and really look at from a council perspective. So that literature has some really important information in the psychiatric residential treatment facility kind of literature. We also have the systems of care, and then there's also literature around transitions for older adults. So we do see, the younger kids and the older adults are the folks that might be experiencing more of the challenges. So I'm going to stop here for a minute and just ask for those of you like Susan and Carol, does this map with what you're seeing from your perspectives?
Rachel, I'm sorry, was that question for me?
Yeah, and you or Susan, I was just wondering, does this, from your experience, does this map with what you're seeing as your studies moving forward?
I think so. The one that I mentioned in particular really was focused on hospital delays. The Department of Health doesn't often focus on experience of children and families as much, or special populations. But I'm happy to have a conversation with folks, just around sort of what is the universe of things that we've looked at, that might be informative for our purposes here. And I think that conversation be great to connect with Diane Rydrick. I'd be happy to facilitate a conversation and kind of talk about her experience. As many of you know, she's been in her role for a long time, and she would be able to provide a pretty good overview of the types of data that we do look at. And we, as you may know, we sit on a lot of data. So if there are future topics, that's also an opportunity to just talk to her about that too.
I think that's great, Carol. And we might kind of just think about this as we go into the activity later today when we talk about evaluation, because we could do that as an interview. We could have her come, or we could, gather information and bring it to the council. There's different ways we might proceed with this, right?
Okay, that sounds great.
What is your thought? Do you think it would be most beneficial because it sounds like once the study's done, it'd be really great to kind of have that information shared with us.
I'd love for them to come to this meeting and present when the report is ready. I think Natasha and I are getting briefed on this pretty soon. That's this most recent study that's about to come out, the Wilder Partnership. And then I think using that conversation might be an opportunity when they come to the council, I think that would be an opportunity to kind of ask about other opportunities or other things that might be useful for our purposes here.
That's great. I feel like, we're not quite sure when it's coming out. We do have the list of dates for the upcoming meeting. So as soon as you kind of get a sense, maybe we try to plug it in. Yeah. And that same kind of conversation with Susan, you're saying that there's data available, and maybe we create an event that kind of digs into some of the data that are not immediately available, but are relevant and important for us to be including.
Yep. I think we're hopeful that we will be ready by the next meeting.
Oh, really? Okay, that's even better.
Yeah.
Okay. Super. Okay. Any other thoughts on the drive-by summary? What we'll do is kind of make sure that you have, like, this PowerPoint has the links to all of these reports, and I didn't include all the reports. So there's a couple reports that I think you'll all want to kind of look at too if you're interested. But I do recognize that you're all very busy people. So there's also the actions that maybe we want to take at this point that help us proceed. So I was going to suggest, as sort of the background people kind of doing some of this work, that we could look at the surveys and the other data that are available from MDH, MHA, and some of these other studies, and start compiling kind of a definitions list that you all could then review. And you don't have to be the ones reading all the reports, but it gives you a faster kind of process to kind of look through. So that was one suggestion that I was going to pose to see if that's of interest. I might call on Jessica. I don't know if Jessica's back. I know you and Brad were talking about source data earlier in the earlier meeting. So I wanted to check in with what your thoughts were about next steps.
I think the reports that you've pulled, I'm just looking at them as you're kind of presenting them, but it looks like they will be linked to source data. Looks like the Department of Health one is the one I could kind of see the best, but kind of like, data that are, primary collected. I unfortunately don't know about, like, if there's a lot of other data that would come from, like, it'd be nice if there was a study in another state or something like that to be able to try to replicate some of those kinds of methods or what types of data that they're collecting. But yeah, I think we wanted to try to stay away from, like, pulling data off of, like, a blog or, a news article or whatever, and instead try to go find the data that's referencing, which I think is what you're doing. Yeah, I don't know. Do you think, Brad?
No, I mean, that's my focus is that if ultimately what I see is us having a report that has kind of a background section and a data section that will then have appendices where we have the data that we considered and relied upon down there. And what I really wanted to discourage was having some, news article as being the data that we're relying on. So these are good areas. I mean, I think we can one of my concerns is that we can kind of get overwhelmed with all the anecdotal data that can kind of come in on these things. And some of us will focus on some piece of data because that's our interest area, or others will focus on another piece of data because they think that data supports a recommendation they want to make. And I think maybe the thing to do with some of this is where the facilitators find the source data that they can put it out to the group, and people can use that as a part of their due diligence to kind of study up on things, so that when we get in these meetings, they can then reference it or point people to it, and we can make the point and move on. But ultimately, I think some of this stuff will be stuff that we will include as appendices or exhibits to whatever report we ultimately end up writing.
Rachel, just one other thought. I agree with all of that. Is it also, I think, would be helpful to try to have some things we could anchor to a little bit, that, like, if we do this well, what does that mean? Does that mean there's shorter stays? Is that, like, what does that look like? And I think that would be a great use of time, both to kind of inform, our current state of being in the report, but then also how progress on this would be tracked, or what kinds of metrics would be looked at over time. Yeah.
Yeah, that's helpful. And when we have the activity later today, we're going to talk about evaluation questions and the outcome measures that go along with each of our evaluation questions that result in the recommendations that we'll make and the report organization. It seems like we're closing in or getting a little bit more clear about how to proceed with the overall kind of outline of the report. There's also some really great examples in the Minnesota reports that are out that will help us do what Brad you're talking about, which is to kind of make sure that we're referencing the source data. For example, the Minnesota Medical Association has some really nice, they like screenshotted MDH data, put it directly into the document, but then also have the links to those sources. So that's kind of, I think, what I'm hearing from you. Okay.
Rachel, I wanted to bring attention to Susan's comment in chat. She is having some echo issues. So I will read this for you, Susan, that she thinks that we should not underestimate the medical complexity in the last item on the list. I'll put that back up for a moment.
Yeah, that'd be helpful.
And
Is that
as much as behavioral resource medical complexity with even more minor mental health contributors is a large challenge.
medical complexity? Okay.
Hey,
Yeah,
sir, I think I've got my echo situation resolved.
Oh, great.
What I was saying is in many of the times this is a combination of these issues. In that very last one, the transitions for older adults moving from hospital to community is sort of like almost looks like a footnote without any bullets under it, but is one of the most significant ones that we see in the MHA data, which I do think has volumes of data, but it's often a combo of I'm a little bit older and a little bit frail, and I have a even more minor mental health concern than somebody if they weren't also frail and elderly and needing a TCU or something. So there's a lot of combinations of these things going on as well.
It's really helpful. And I think you see that, like I pulled stuff, Susan, so I don't think it's necessarily, I think reading the reports is really helpful because I think they do emphasize that medical complexity issue and older adults as its own separate complex kind of area. And I think one of our conversations in the last meeting was how do we proceed with the disparate kind of groups that have these challenges? And it might be what we do is kind of focus in on trying to address some of those more frequent types of challenges, knowing that they're still very complex, like you said, and require kind of like a systems of care kind of approach to addressing the different, numerous complexities that are involved in the process. And I'm getting that pretty strongly from these reports too, that this is not an easy solve. Okay, and I did hear the echo, Susan, so I know exactly what you're talking about. And thank you for doing the problem solving around that, because I know sometimes it can be difficult to hear when there's the echo thing going on. So thanks. Okay, well, Jen, can you put the slides back up?
Sure.
Let's see, how are we doing on time?
So I was just going to say, we have 9 minutes left on this section.
Yeah, and I'd like to spend that time making, you all did such a nice job last time of like really getting some clear recommendations. I have one slide next that talks about like certain keyword searches that I may not be tracking that you think will take us in that direction. So Susan, like I think about older adults, I found some of that literature, but if you have keywords or kind of areas to focus the search, that could be really helpful for us. Because we don't know everything about everything in the universe, but we can go find it. So if you have thoughts, we'll write those down. You can put them in chat if you want, and we can review chat. I'm just wanting to make sure that we are thinking about the different types of ways in which we're looking at the literature search.
I'll think about it. I do think that some of these challenges are very recent, so there's not as much the published literature, you're not going to find 2016 data on these new existential crises that we have now post-pandemic with a different environment and different capacity out there.
I think that's true for the hospital discharge delay. I
Yeah.
think the part around transition planning, I know there are some different areas, and I feel like there might be some suggested sorts of strategies that might not be directly related to kind of that escalation that we're all experiencing. But I know exactly what you're saying, Susan. Like you can tell from the search, the blossoming of discussion around this increasing pattern over time. Okay, so if we don't have any more search terms, what I would suggest is we think about actions. What do you think is going to get us to the next stage? One thing that I don't know, Jen, if you put it in as an action, but it would be something for the council to consider is what you want us within the facilitator group to go do next. I think one of those things is maybe to, like Brad said, try to organize a page so that you can do your due diligence and look at the different reports and information so we can get something together, and maybe just, if it's okay, Stacy, put it on the website because they're all publicly reported documents. That could be, one of our next steps. I feel that, kind of trying to map out the report is going to get a little easier when we do this activity in the afternoon, because I think that's where we're going to start talking about evaluation questions and specific ways to answer the questions. But anything in this category, that would be helpful. I did, like, the Minnesota Medical Association has a really interesting map of the state of Minnesota. And it talks about, bed capacity and where those resources are. So that's like a really helpful thing, I think, for people to see. So what we can do is kind of try to maybe highlight some of the page numbers that can take you quickly to some of the things that are helpful, or screenshot them and put them into something that, Brad, I don't know if this is what you're thinking. Like, I know having a list of the reports is good, but you're all really busy. So kind of trying to come up with something that starts to maybe summarize major findings that are going to go into the report. Oh, Brad's making a big list here. Okay, I'm going to make recommendation here to focus.
I just wanted to kind of focus everybody. I mean, I think the literature is great. I see that as going into the creation of kind of a background and history for a report. But ultimately, we're going to have to turn out a work product in 5 months' time.
Right.
And so I think kind of getting what that outline looks like and how it shapes up and creating deadlines around that would be helpful. And so I just wanted to throw out a suggestion. I'm not wedded to this. Other people may have other ideas, but I wanted to kind of get people thinking about the work product we're going to need to turn back to the legislature in October.
So comments, thoughts, it's in the chat that Brad has organized an outline for the report.
I agree. I was going to also suggest if we get a report outlined, it might kind of help us understand where some gaps are that need to be filled in. It would be nice as we move forward doing this, like if we have an editable version, or, it just, how can we all get edits in or suggestions in kind of real time, knowing there's a lot of time that lapses between the council meetings. Because I think like population is a really important component to this whole thing, and where does that kind of come up in here?
Mm-hmm. Yeah, so you're suggesting taking maybe what Brad started and mapping in some of the pieces that we need to make sure that we hit and where they might fall.
I would agree that this is a really important step to get some of this information out sooner than later, to give everyone time to review it and suggest edits. I think this is a great idea.
Thanks, Jody. Looks like people are on board. Just as a report out for those of you live streaming, people are, Brad has put an outline of the report into chat, and Janelle is indicating support for this, as is Carol. We definitely have, an action coming up that might be to have some further introductions to Minnesota data, possibly at the next meeting, depending on timeline. So that, I don't know, Jen, if you're catching some of those things that we want to make sure I think they're more actions, unless somebody wants to make a motion. You guys did a great job last time, kind of, pushing us forward.
Yeah, I can move to put forth a outline based on what Brad put together and get the report started.
Great. Do we have a second?
I'll second my own outline. So
Any discussion? Oh, sorry, go ahead, Brad. I didn't mean to interrupt.
The only thing I wanted to say as a point of discussion is obviously we've got some of the council here or group missing and including some of the leadership. And so all I'm suggesting and what I'm hearing from the motion is that we have an outline that is generally along these points, but I think leadership in the group and others need to be able to weigh in. So if we can come back to the next meeting, and that's what I'm kind of envisioning, is seeing an actual, I don't know if you want to call it a Word document or something like that, but actually has the general outline of it and maybe the beginnings of something like an introduction. And then we can start assigning drafting or figuring out who's going to be drafting things or grabbing onto ideas or creating a list of, yeah, this should go in the appendix. This is going to be cited in the background. We can then start to envision what it is we're ultimately going to have to come up with.
Okay, I want to revisit this. So this is going forth as a motion or an action item?
It's a motion with a second, but we went into discussion, and the discussion is that Brad was saying that maybe this is pending the next meeting. So maybe the motion's written in some sort of way. You guys can help me out here.
Yeah, so that's what I want to know is,
the facilitators will begin organizing the report pending the next meeting, where we'll have, more members available to move forward. I don't know. Jessica, your thoughts as a motion initiator?
It would be nice to have us all understanding it's a working draft, Word. I mean, I don't know if we're allowed to use something like Google, but a Word doc or something editable, because we want people to be able to give a lot of input. But I think by the next meeting, it would be okay to come with that, but knowing that not everyone's here, and you all meet sometimes with the leadership outside of the council meetings, right? Maybe you could even have some of those discussions before our next meeting.
Absolutely. We meet with the chairs prior to this meeting. So maybe it could be the motion gets adapted to the facilitators will bring the content from the meeting to the chairs, and for organization of something to present to the board in report form. I do want to, as we're still in discussion, ask from a perspective of the public versus, writing report sort of process. Is there something we need to do to make sure that information is available publicly as it's in development, or is it something that we are working on within this group and sharing out within the open meeting process? And Natasha, I think that's kind of directed at you.
Can you repeat that again? Sorry.
Yeah, sorry, I didn't say it very well. I'm wondering, in the process of writing a report in this group and getting access to people who can see it, is that a public process that we need to somehow create a way for people to see the iterations as we go, or?
That is a great question that I don't know the answer to off the top of my head, but I think we can chat with some folks here at DHS and get clear on that, because it does seem to me that it's going to be important to have some type of a shared document for council members to be able to put comments in, to, you know, add things, blah, blah, blah. And so I would, you know, hope, and I'm sure there is a way to get that done within the bounds of public meeting law. So we can take
And
that
I believe
back.
that was done in priority admissions too,
Okay.
where it was an open source document for the membership of that task force. I'm not sure if they then, you know, then they would attach things to an agenda for their periodic meetings, and that would become then public.
Right,
But
the
I'm not sure
drafts
how to
themselves, yeah.
Yeah.
Okay. So that tells me that task force would have been subject to the same laws that this one is. So that tells me there's definitely a way. So we can figure that out and bring that back to this group so that it makes sense in terms of the tool that we're using to draft together.
So that appears to be an action we need to capture, not necessarily a motion. And we're still in discussion for the motion. Jen, are you doing okay with that? Do you feel like you've got what you need? We just need to investigate the public reporting of the document and development.
Yeah, so I have an action that we will investigate the public reporting of the document that's in work. The other thing is, I think what I heard was Jessica moved forth with a motion to put together an outline of the report. Brad seconded the motion. Through the discussion, it looks like we have a motion to amend the first motion, right?
Well, I think it was just a clarification of the motion that it's a working draft.
Okay.
Yeah.
I think that works, Brad, because that way, you know, we'll bring it to, and that's the other action, Jen, is that we'll bring this to the chairs prior to the next meeting. And then
And the chairs may come back with some kind of a recommendation to revise the outline, you know, and that's fine. Part of the process.
And Natasha, would it be appropriate just to put the public Minnesota documents that are already available online onto the website so that people could just access it there? Or we could, you know, because now we've got a Word document that's going to be in process. We could just put all the links into the appendix of the Word, you know, the report. Or we could, you know, it might be helpful for the public to be able to see these reports as well. So we could put it on the website in that section on resources.
Yeah, I think it makes a lot of sense to directly link to the studies on the public website. We'll still include, I mean, I'm guessing we'll include the links in the report itself, but sometimes when you're linking, it can.
Right.
Those things.
So Brad, does that satisfy you? Because like you had said, it'd be really good for the committee to be able to access some of these things and do due diligence and dig around if you want to. We can put that into the Word draft report, but also have this up available so the public can get access to the report and then just separate kind of navigation systems. Is that okay? Okay, cool. All right. Well, we are past time. I kind of figured this one would take a little bit longer. And what do we have next, Jen? A break?
We need to vote on the motion.
Oh, shoot. Yeah. Sorry. Thank you. Okay. So we are in discussion. We just need to, Jessica, we just need you to do the, is this a roll call or
This should be a roll call, and Jessica, do you want to roll call this?
I'm not sure. I'm sure who is a council member and who's not. So is there any way to do it
I
then?
can roll call it. Yes. Okay. Where are we here? Okay, Tom Delaney. Let me
Yes. Oh,
the motion.
maybe not.
Why don't I restate the motion so you know what we're motioning on? And all right. Actually, I can. I'm not able to do my chat, but I will share it. The motion is to put forth an outline of the report and to ensure that it is accessible and editable by the council. All right, so Tom Delaney.
Yeah. Yes. Yes to the outline.
from Randy Baumgardner. And you can either verbally vote or give an indication. Randy, I'll come back to you. Brad Johnson, yes or no?
Yes.
Right.
Yes.
And Joni Donna.
Yes.
And Nicole.
Yeah.
Jessica? Yes. Natasha?
Yes.
Mary?
Yes.
No?
Yes.
Randy?
Yes.
Carol?
Yes.
And Susan?
Yes.
And Cindy? And that could be either verbal or in chat as well. All right. So I just want to double check on Cindy St. George and see if there's a vote coming in. Okay. All right, I think we have everybody who's here has voted. And so the motion is approved. 1, 2. All right.
Great. So I was all anxious to go to a break, but I think we've got everything now, Jen. Are we good?
We are good.
Okay. So let's see, we're supposed to start our evaluation question at 10:40, which we're at. Is it okay if we just give you 5 minutes? Do you think you need a little bit more? Okay, just do a quick break, get your drinks, kind of get some food if you're starving. We'll be back in 5 minutes.
Hi there. Hi there. It looks different. Yeah, I know.
How's it going?
Good. I'm consumed with
I should get this next thing set up for the activity. And Danny, you're doing this with me, right? Let's see.
I believe that was the plan.
Yep, that's the plan, Stan. All right. So when you get back, Jen, just put up the agenda again, or the PowerPoint.
Do you want the agenda or the PowerPoint up?
Yeah, sorry, the PowerPoint.
All right. I want to note that Carol Backstrom needed to leave, but you still have a quorum at 11 people.
Oh, good. Great. All right. So this goes along, I think, well with what Brad's suggesting for the report. What we want to do is go through guiding questions that we're asking. And so if we go to the next slide. When we think about what we're doing here, we're looking at our evaluation and basically thinking about the questions that we have. And we've got 3 that are pretty clear, but we might have some additional questions that we want to ask. So we're looking at that and the types of data. And so once we kind of get clear about our what we're trying to ask, it helps us understand how to deploy like focus groups or interviews. The example earlier was we might talk to Carol's colleague and dig a little deeper around the types of data MDH has. That's kind of like an example. So go ahead and go to the next slide. Okay, so just on a basic level, we want to know what questions we're asking about the acute care barriers. And we want to describe those in enough detail as we think about this, that we can have a plan for moving forward to really think about what, for instance, interviews or focus groups, those kind of things we need. We are zeroing in on our quantitative data with the discharge delays, but there may be some other types of data like the positive support information that kind of helps us set the stage for recommendations that we want to ask. I know Natasha mentioned the idea of a survey possibly. And as Brad has pointed out, we only have a few months left, so we're going to have to move pretty quick. I think it's doable. And so what we're going to do is kind of zero in on finalizing the core things that we want to ask and what data we want to collect as we proceed, and kind of craft the messages to the legislature based on sort of that foundation of evaluation. Go ahead and go to the next slide. So just as a basic logic model sort of approach, we've been in inputs, right? We're thinking about the situation of acute care, the priorities that we have. We're talking about inputs and the kind of things that would help us answer the acute care barrier question. We look at our outputs, and those might be the activities and the participation that goes on. So things like going out and getting some interview data, going out and doing some focus group and data collection, those kind of things. And that leads us to short-term, medium-term, and long-term sorts of outcomes. Clearly, with the 5 months, as Brad pointed out, we don't have a lot of time. So in the short term, it's really organizing the report so that we can move forward. But we're wanting to make sure that we're thinking about those long-term outcomes and impact as we think about this report that we're writing. So if you go to the next page, this just kind of maps out those with little examples. I know it's pretty small here, but it's just meant to kind of give you like generic examples of what inputs are: staff, volunteer, time, money. In our case, it might be the funding that goes into moving Minnesota. It could be the information about the DHS funding that goes into positive supports. It might be about the hospitals and what kind of things that they're doing to address the crises that they're dealing with. So you're thinking about those, and then what are we going to do? Who are we trying to sort of understand the problem from their perspective? And then we map out those outcomes. So this is just a drive-by on organizing our evaluation questions. And if you go to the next slide. So this is the same thing that you just saw. You've got inputs. In our case, we're gathering information. We just went through the discharge delay. We went through Amy Peterson's presentation. We went through the positive support information. So we're getting those inputs in place. We have the activities of the council meeting, but we also are accessing data, and Susan's helping us with that. We need to deploy some focus groups just to kind of gather some more information. And then we will look at outputs. So the council report will summarize all of the things that we're gathering. We might have a glossary. We might have some definitions that we're anchoring to. But that'll lead us to the legislative recommendations, right? So our short-term outcome is by October that we'll have this report that goes through legislative sort of recommendations. But on a long-term basis, that hopefully will lead to new policies. And we focus things like incentives for people providing services, for providers, for hospitals. We look at, how do we create that context for both the situation around the need for beds or ways to support people and the transitioning out into the community and the importance of having that capacity building. So that's kind of the logic of moving forward with this report, is that we want to have sort of logical sort of flow and think about our data in a way that allows us to kind of answer what we're doing in a logical sort of flow. Okay, so excuse me, if you go to the next slide. We have, and Jen, I know you kind of worked on this one. I don't know, and Danny, you, the three of us kind of worked through these. So all three of you should jump in and help me with this. But these are the three questions that Jen showed you at the beginning of the meeting, right? Improve regional capacity. This is in the legislative requirements for us. And then create a measurement system and look at statewide strategies to address geographic, racial, ethnic disparities. Those three major targeted goals for this council can be, organized into an evaluation question. And Jen, I believe you kind of organized this as an example, right?
Yeah, we just walked through the purpose of the council going through the logic model guiding, thought process here of how are we turning these aims into evaluation questions that guide then the data that help us answer these questions that will then eventually give that data informed process to the recommendations made by the council. And so we just put in some examples here, but it really opening it up then in this activity that Danny and Rachel will facilitate on what your thoughts are regarding the data and how these could link to that ultimate report. But so things around. Oh, go ahead, Rachel.
No, I was just going to say the example that Jen has comes from the presentation today. So how do we improve regional capacity for acute care transitions? One is that we could look at the DHS, funded trainings around positive supports and look at what the data are telling us. So that's something that we could gather as a source of data. And that's what Jen kind of put together for us. We have a series of reports that have been occurring since 2020 that we could pull from in just the same way that we just did with the discharge delay kind of issues. And so we also might consider, and this is what Jen put down, focus group with the individuals or families impacted. We could look at the differences that are occurring across different regions. This reminds me of that Minnesota Medical Association map where they've got, a map of where the places are where there's some opportunities for additional supports for people and that sort of thing. So anyway, that's kind of what we're moving towards for this discussion. I don't know, Jen and Danny, the next slide is kind of the open section for asking questions, right? Okay, so let's go back to this slide. And then just think about, and I was kind of wanted to ask Natasha, do you have thoughts on what types of data we would want to collect around regional capacity? Like I know we could do something around a focus group with folks that are doing regional team meetings, or we could send out a survey or, kind of look at different things. What are your thoughts, Natasha? Are they having trouble? connecting. They're on mute. So I don't know. Maybe is she there? Okay, well, we can keep going. I think the next one is something that we're acting on right now, which is create a measurement evaluation system using implementation science. So we talked about earlier, the question might be posed as how do we create a measurement and evaluation system using implementation science, but we have we talked with Carol and Susan about looking at, some anchor definitions around discharge delays. And so that could be, when we look at the data sources, it could be the reports. But it also might be that those of you in the hospital settings might have some suggestions for how we proceed. I know we've talked to some folks in Fairview and other hospitals that have been interested in different types of data that might be helpful. And then the third one is the statewide strategies for addressing geographic, racial, and ethnic disparities. So what are the statewide strategies that can be identified? And I have found some reports that are part of those 8 reports that are around Medicaid and disparities. So there are some sources of data, but we need to think about how do we collect this information? And I know we also have our tribal nations that we want to make sure we're gathering information from. So Danny, what are your thoughts about, how we might structure some of the questions on number 3 for data? That's I know we've talked about maybe reaching out through interviews.
Yeah, I mean, I do think that if we're going to be reaching out to some of the underserved communities, it would be best to reach out in person and to be able to do that rather than a survey for sure. That seems to be where we would get the most accurate and the most information. So, I mean, that would be my one thing that I would be really strongly encouraged for under that number 3.
Yeah. I mean, this overall issue does seem to be another thing that we could, as facilitators, get organized to bring to all of you, but we want to make sure you have a chance to add, for instance, maybe we have additional questions. These are the 3 that comes out of the legislative mandate to have a council. So these 3 are, kind of non-negotiables. But if you go to the next slide, we have some, open-ended sort of areas for us to kind of explore. So are there other evaluation questions that we would want to make sure that we're asking? I think that's, or maybe a deeper dive into one of the 3. That might be another way that we could generate some ideas about how and what data we're collecting.
Rachel, I want to note that it looks like the room is muted where Natasha is, but she has put into chat here to Rachel's question. I would say that any effort to talk or get information from regions should be focused on what capacity providers and lead agencies have or don't to support people with complex needs in the community.
Thank you, Natasha. I actually think that a focus group on kind of the lead agency across regions could be really important. It could be one focus group with different regions, and we could ask them from their own geographic kind of perspectives to share what we need to be considering. Is that kind of what you're thinking, Natasha? You can put that in chat. Any other thoughts on, yeah, I know you're muted. You don't have to, you can just put it in chat if you want. We can report out to the group what you're thinking. You're probably multitasking though, so I get that too. You don't have to do 2 things at once.
So this is Jody, and I would just comment definitely in support of what Natasha is suggesting. I think hearing from lead agencies, specifically about the struggles that we're seeing with trying to locate appropriate placements for homes really for people with complex needs, and also just about our resources and the ability to do that work on an acute care timeline. I think would be incredibly helpful.
That was Jody, right?
Yes.
Okay,
Yep.
Jody, I wonder if we should, like, if we for sure think a focus group is good, we could actually get some of our questions based on some of the stuff that we looked at today within the data. So issues around guardianship and other types of things that maybe our lead agencies might speak to. Is that kind of what you're thinking too? Like maybe break down some of the questions for them within a focus group?
Yep, absolutely. I think that would be incredibly helpful. I know that the MAXA membership probably would be more than willing to, there's a lot of counties with thoughts on, you know, how this work impacts our work day-to-day basis. So the insight would be valuable.
Great. That's super helpful. I do think, you know, if there are things that our hospitals need to unpack a little bit more, like Carol also mentioned the idea of interviewing the MDH folks, like this would be the time for us to think about making sure that we know, you know, who we need to interact with, and especially for those 3 questions. But if we had some deeper dives in the way that we just talked about, we'll definitely get those written down as well.
Rachel, just a quick sound check. Can you hear Natasha?
Who's speaking right now?
Natasha, can you hear me?
Oh, yes, I can hear you, Natasha. I wasn't sure if it was you. It didn't sound exactly like you, but yeah, I can hear you now.
Awesome. We are unmuted.
Success. That's wonderful. Yeah, so Natasha, if you have any other additional questions, we've got the major 3, and what we might do if you want us to is kind of unpack those 3 and kind of put sub-level questions and the data that could answer those. That might be a way to proceed.
Yeah, I mean, that makes sense to me.
All right. Yeah, I think increasingly, given the timeline and you know, Brad, your comments earlier, if we can just kind of organize so that we're getting stuff back to you and kind of moving forward so that we can execute those focus groups and interviews as fast as we can, that'll be a really good step forward. So I think from an action point of view, Jen, my suggestion to the council is that we have some finalized questions and the data that answer those questions that we can bring to the chairs. So we'll follow the same motion process that we did earlier, and bring some working kind of documents that would go into the report to just get our decisions made about how to collect information.
All right, so Rachel, just so to clarify, I'm documenting that as, and to the council, I'm documenting that as an action item, that the facilitators will will finalize, bring a list of questions and the data to answer the questions to the chairs and bring a working document to the council.
I mean, we could count it as the earlier motion, to be honest, because it's part of the report. So I don't think we necessarily need to do any new motions for this, as long as everybody is okay with this kind of strategy. It'll just keep us moving faster, which is better. So that'll be good. And I do know we're probably at open session now, right? How are we doing on time?
Open session we're into open session at this.
Yeah. So let's go ahead, unless anybody has anything else to add, we'll go ahead and move to open session. And so Natasha, that we hand this over to you. And also if you have questions in your live streaming and you want to email those to us, please feel free to do so. You can see the email address here on the open session document.
Thanks, Rachel. And we have one person in the room. Do you wish to make any comments, sir?
No pressure.
No comments to be made. Thanks for including me.
Okay. But feel free to send in emails if you're live streaming and you do have some questions. And if there aren't any open session comments, we can move on. So we are, I mean, it seems like we've been doing some of this, Danny, which is, preparing for the next meeting.
Mm-hmm.
It might be, what do you think, Danny? Should we ask Jen to just kind of go through and list out everything that we said we're going to do?
I think that would be helpful.
I can't, it's always such a whirlwind going through all of this.
All right. We did have one comment.
Oh, thanks, Jen.
That
We
came
get one
in.
open session comment.
Yeah, so I'm gonna pop
Yeah.
up that open session, but one email came in around, please have more focus on individual and family experiences in each meeting with adequate time so as to not rush people, and please expand time in each meeting to feature people with lived experiences to tell their stories.
That's great. All right, so that'll lead us to the next planning session that we can explore further. So what do you think, Danny, for this open session comment? One of the things, I mean, I do think we should go through the list, but we might speak to the comment now.
Yeah. I think that would be really, really good, is to have like a special focus group too for people with lived experience and people who are families of people with lived experience. I think that's a really great idea to be able to do. So, Rachel, I'm not quite sure what you're asking me to do here.
No, it's okay. I'm just trying to process this, and it looks like part of it is this meeting itself. The request is to make sure that we have some more stories within the meeting. And so that might be something that we talk about right now. Do we want to bring somebody in to kind of create that context within the next meeting?
Yeah, I would open that up to the council.
I'm having trouble understanding what the request is.
And I think that Stacy, if you wanted to email to that person, but my sense of it is that the person is in a live stream watching this meeting and asking for us to talk more about families' experiences and to maybe have something that anchors some stories around lived experience. That's kind of my interpretation of this. And Stacy, if you have anything to add, please throw it in chat.
Mm-hmm.
I mean, it makes sense to me to make sure that, like, I think, Stacy has had the value and vision statement up to make sure that we attend to kind of making sure that we have those experiences. But I think it makes sense to consider that as part of the process. The New York report actually starts with the story. So maybe that's one thing that we could do, is look for a really good story. And we do have some colleagues in the hospital setting that might be able to help us, that we could use in a way that helps to anchor the report and to bring to this meeting. So that might be a problem solve for preparation.
I mean, I kind of view those things as being suitable to go into kind of the background information in the report. Maybe the story could even be made a part of the report as one of the appendices or an exhibit. So you can kind of reference the report, reference the story in the report, and then have the full story there, or have significant quotes from the story. And I think that's helpful. I do want to be careful that just because of the work that's necessary to get done to write a report, that we're not, I think we should be accepting stories kind of throughout this whole process and finding a way to get them out to people. But the meetings, there's just not enough time to listen to individual stories, I think.
Well, I think that's a really good solve, though. One of the things we could do as part of the process is ask for stories to be shared in a way that we can utilize those. So it would need to be set up so that we could either de-identify them or if the person is okay with sharing. But that would be a very powerful way to bring the story to the public. And I think the other piece of that that you're talking to, Brad, actually gives us the ability to, like Susan mentioned earlier, there are medical complexity related issues that families are experiencing. There are young people with guardianship issues that are having experiences. So there's these different people who are experiencing the barriers to transition. And so having a way to kind of express that in a really concrete way would be good.
I was even going to suggest that, you know, so much of society now shares stories through video clips and things like that. I mean, if we had a mechanism for people who wanted to kind of upload a story to the council, to either upload a written story or clip or something like that, I think that'd be a really
Great. If somebody is on, has their unmute on, I know we're getting a little bit of sound, so.
Well, I wanted to acknowledge too, I think, Randy, did you unmute in order to make a comment as well?
Yeah, I'm one of those people that spent a long time in the hospital, 3 months before they could find me placement. Then the placement didn't work out, so I spent another 3 months in the hospital for no reason. Because they couldn't find a placement for me.
And Randy, your story,
You know, because of obesity.
Mm-hmm. I think your story is really important, Randy. So we could, if you were okay with that, we could include that within the report as well, because it gives you a really concrete example of the challenges that people are experiencing.
Yeah.
Thank you.
Thank you.
That's great. And I do like the idea of uploading. I think we can bring that to our team and see what kind of things we might be able to do. And then, you know, I don't know if Randy, you'd be willing to help us kind of create that. We could work with you, you know, to tell your story if you were interested.
Sure.
Great.
That's pretty much why I was invited to this.
Mm-hmm. And Susan was making a point earlier that your story is one of those that is clearly a more pressing issue, right? There's more people with medical complexity issues that are experiencing discharge delays.
Yeah, because a lot of like nursing homes and physical care places don't like taking anybody over 350 pounds.
Yeah.
So that's where I lie in. And the care that you do get, they can't handle somebody over 350 pounds usually. But luckily I found that I ended up in this place I'm at now, and they seem to be dealing with me really well. So
that's great. Good.
But there's very few places.
There are very few places, yeah. So I think your story is one of those areas that we want to make sure that people understand really well. So what we will do for an action, Jen, I think you've probably got that listed, that we'll kind of work on something that gathers stories like Randy's and others so that we have sort of a range.
I did. I added that, yeah, to gather. Yeah, stories of lived experience. We also, Stacy in chat reminded us that stories can also be shared via the council email as well. So I think there are multiple avenues that we can take some actionable steps on, as well as the natural communication path with that email.
Great. All right, so then we'll go back to what Danny mentioned earlier, which is kind of maybe just preparing for the next meeting. We just list out the things we've got so far.
Yeah.
Right. Do you want me to review those, Danny?
Yeah. Just so that we know exactly what we need to be doing by our next meeting on June 4th.
Okay, I'm going through some of my notes here on action items. I think one of the first action items is around the organization of the report templates, the outline for the report, and making sure that that report is in a format that is easily accessible and can be modified by the council.
Could you, is this before, I think this happened before, which is the discussion about MDH coming to maybe the next meeting?
I have, yep.
You do have that. I'm sorry. It was just, I felt like it was out of order.
So it was, I'm sorry. It was.
That's okay. You can do it any way you want.
We have an action item to have some further introductions into the Minnesota data coming to the next council meeting. We had a discussion about investigating the public posting of the document, and I think we just need to finalize that discussion. And bringing the report outline in an accessible form that can be edited to the council.
Sorry, did you say we needed to talk about something about that?
The public posting of the document was a discussion that happened.
Okay.
So we need to finalize that decision.
I think that, Natasha, you thought that was a good idea. So I think we got some confirmation on that. Is that right?
Yeah, I think there's an action item that DHS can work with ICI on in terms of just assuring that whatever mechanism we choose to do that meets public meeting requirements. So we can do that internally and, share the outcome at the next meeting.
So it's almost like it's kind of like a process that will kind of look at the different the ways in which we need to report the work being done in the way that Brad kind of pointed out. It happens in other meetings, and then also that part that we're talking about with the website posting, Jen. So that'll be like a clump of content or a theme we report out on, unpack.
Susan has her hand up.
Yeah, I'm just wondering if in addition to MDH, if we are interested in having MHA come and present the data. I think we can still get the raw data, but I think they've already done some work to sort of collate that into the themes, the volumes, the anticipated impact of those. And I know they were willing to come today. So they'd probably be willing to come next time if that's something we want to add.
Thoughts from the group? Thumbs up, thumbs down, questions?
This is Natasha. I would certainly support that.
Okay,
I think having that is really important, but also, I think to someone's earlier point, we need to be able to get the data out there in a way that's digestible, given all the different sources of data that we're looking at. So,
Susan, is the presentation that gets developed, would it allow us to do what the council was talking about, which is like kind of have that PowerPoint be the source that summarizes data in a way that has an anchor to the source data?
I believe so. And I think we could have both, have the source data and sort of that interpretation at scale.
So it sounds like the next meeting, we're going to have two, hopefully MDH will be ready to report out. And then Susan, your group that will make an invitation to present, kind of to finalize that kind of information coming in as part of our assessment. So that sounds like it would happen in the beginning, probably, right? The meeting. I mean, obviously we got to bring this to Josh and Laura as chairs, but just thinking out loud. Because we'll also have the report, you know, and so that information will come in and then we'll go to the report, you know, review. Great.
Yes, so I just made note of that. And then the other elements of action here are around evaluation questions for the report and facilitators taking the primary questions and using the data that's already accessible to detail those questions. Bringing those back to the chairs and a working document back to the council.
Great.
Does that sound correct?
Yeah, Brad has a comment. Danny, you want to read that out?
So I'll just read it. Our first listed goal is improving regional capacity for acute care transitions. Could we put on the agenda asking members of the council to come to the next meeting to talk about their thoughts and visions on what the regions of the Minnesota should look like? Might be a short-term and long-term vision for the state. What will help us consider regional resources, workforce, infrastructure, or lack of that, and policies related to a regional approach.
That's a great idea.
Mm-hmm.
I know you mentioned that before, Brad. That seems like a good conversation to have so that we have a way to discuss the different regions in a way that makes sense. I know in our work within training and technical assistance, regions like to self-identify, but then we also have those clear demarkers from different perspectives of the system. So I think kind of coming with the different perspectives of how we organize the state by region is a really important thing, and that maybe we come out with. Brad, are you thinking a definition of how we talk about regions?
Yeah, I mean, we might end up in a conversation about what do we want the state of Minnesota to look like 20, 30 years from now, but that might not be a practical solution to the problem. It may be that because we need to get there, we need to think, what can we do in the short term? And then where do we ultimately want to end up with how we handle acute care transitions in Minnesota into the future, so that whatever is a recommendation that comes out of here speaks to the future.
That's great. All right. So I think what we have then, Jen, is one motion and a list of actions. Is that right?
Correct.
For this meeting. Okay. We actually are, done with the standard agenda here. We kind of blew through the open session without a lot of comments. Is there anything as far as business that we need to cover in addition to the things we've talked about?
Rachel, I just want to clarify really quickly that we had two motions. One was for the agenda and meeting minutes. The second one was for the related to the report outline.
That's right. That's right.
So I wanted to make sure that was accurately reflected here.
Thank you, Jen. I appreciate that. A question for Natasha. If we finished our business, is it okay to close early, or do we need to continue working? Because we could target another topic area.
I think there's no reason we can't end early. I think I would, ask this group if you'd like to either, spend 15 minutes with general sort of open forum questions and answers and discussion, or if you'd like our facilitators to, move ahead to another piece of agenda item given the time we have. So I think there's kind of three options. One, close early. Two, just some open discussion and dialogue. Or three, if you have agenda items that you could move into. So that would be, I think I'd like the group's, you know, feedback on that. I don't want to make the call on my own. Maybe people could put in chat which option they like, if that makes sense. Or speak out loud, of course.
Yeah, the one area that we could keep unpacking is the evaluation questions and data. I see Tom's got to head to another meeting at 11:30 anyway, so that's Tom's perspective. Anybody else? Me too. So some people are feeling pressure to move to other meetings.
You know, what you probably could do is move to adjourn the meeting and close it for official business. But if people wanted to stay on and use the time allotted to informally do things, they just can't vote on things or make motions or set policy. So
let's do that, because I know you're all really busy and Tom's got to go. Thank you for being here, Tom. We'll see you later, and we'll we need our chair to close.
I'll just make a motion to adjourn.
Okay. We need a second.
I'll second that.
Okay, all in favor?
Aye.
Aye. Okay, thanks. And so for those of you who want to dig deeper, we'll keep working on getting this information together for the next meeting. Yeah, I know people weren't as talkative at this meeting as they usually are.